back after the recess. Today we've a busy agenda. We will be getting a briefing from the department on the programme for government. As you know, the committee will also be considering 3 SL1s and a written brief updating us on the ongoing implementation of the hospital traffic management systems. There's a substantial list of correspondence, as you'll have seen from your pack, that we need to agree actions on, and then the committee will consider our forward work programme in closed session. So just we'll open the meeting now to the public. Members, the committee meeting will be recorded and broadcast through Parliament buildings and online. And just to remind anyone in the public gallery, they can use mobile devices as long as they're in airplane mode and are muted, but it's not permitted to take photographs or record any of the meeting. I have one apology from Colin McGrath. We have Linda Dillon online, and I think Alan Robinson is planning on joining later on as well. And I've no other apologies at this stage. So just item number 2 then under Chair's business. There's a couple of things I wanted to mention. The first one will be members. We met with the families of the deceased patients of Michael Watt on Tuesday, and I think it's important that we thank all of those who attended for sharing their really harrowing experiences in terms of seeking justice and the truth in relation to their relatives. I've already, as agreed at the meeting, I've already written to the Minister to request an update on the meeting with those families by the Minister who are going through phase 2 of the process, and to request that he urgently meets with the families that have gone through phase 1, which will be those who we met on Tuesday, because from what we heard, their experiences haven't necessarily been very good, and there's still a long way to go on their journey, and we want to make sure that that's moving at pace and that they're getting what they need from it. So we will continue to take the issues raised forward, particularly when we're considering our committee priority under accountability and promoting best practice, which we will discuss for later in the meeting. And we had, I was going to ask members if we could consider, and we can discuss this later, the potential of a committee motion around duty of candour, because I think that's something that has come up. And a number of members have now raised that also. It's been coming up with various families and individuals we've met who are going through inquiries similar to that of the Michael Watt patient. So I think it would be timely if we could move on some of that. So are members happy enough then? We can discuss that later. Nuala?
Yeah, I just wanted to say, because I know that there are maybe others watching, just to put on record our thanks to the families that did attend on Tuesday. I know we had met with George and Colin before, but I think it was just so important that we all did meet and hear from them and the grief that they're suffering and being, kind of re-traumatised by not getting the answers they deserve. So I just wanted to put on record our thanks, and that if there are any other families as well, to reiterate what their RQIA had said, that they said for people to reach out to them, and if people need help as a committee, that we're here to listen.
Oh, absolutely. And I think to hear those experiences firsthand was so important for us as a committee as well. Linda, and then yourself, Diane. Linda.
Thank you, Chair, and again just to thank the families. It was a very emotional meeting, very difficult meeting, and clearly re-traumatising for the people that are having to continuously tell their story. And that even concerns me that they're not necessarily maybe getting the support they need for that as well. But I think just in terms of RQIA, and in fairness to the families, said that some had not had the best experience necessarily of RQIA, but some actually said they had a very good experience with RQIA. But the problem was that RQIA did not have the teeth, or did not have the powers that they needed to actually hold the health service and the system to account. And I think we need to, we did have a briefing with RQIA and we have looked at this, but I think we need to seriously bottom out what it is that needs to be asked of the department in terms of improving that, both resource-wise and potentially legislative.
Absolutely. Thank you, Diane.
Yeah, no, really just to reiterate and reinforce from my point of view as a new member to the Health Committee how really important it was to hear from the families. And as Linda said, it was a very emotional and difficult meeting for those families, and we do offer them our thanks. And just to take that a step further, we have now as a committee met and engaged with a number of people who have been terribly failed by the health service. And I told the story of Erin Harbinson at the meeting. And that again is an incredibly emotive, terrible issue. And I do think it is really important to discuss a committee motion around a duty of candour, and I give my full support to that. Because in the common thread that runs through all of this is the difficulty in getting information from the health service for those individuals impacted. And I do think it is a very timely motion to bring forward, and I think would be supported by a lot of groups out there who feel they've been failed.
Yeah, no, absolutely. And I think that's kind of what I was thinking along the lines of as well, because we have, in the short time that we've for this mandate that this committee's been in place, we have heard on countless occasions now of examples of where that's happened. Orlia?
Yeah, no, I completely agree with everything the previous speakers have said. It was just to add to that, so maybe in advance of submitting the committee motion on the duty of candour, I know that there was previous requests that had come into the committee from families that have been impacted in various different ways who had requested to meet with us. So I know that the relatives that we met with the other day, and it was a powerful session that was specific to the Michael Watt case. But I know that there was separate requests also that come in. So it's maybe just if we can take another wee look at that to see if there's a window where we can do another informal session to make sure that we're speaking to as many people as possible before we speak to the motion.
No, absolutely. Absolutely. Thank you, Orly. I think that is crucial, because whilst there be common threads, everybody will have had a different experience, so it's important if we can get as much information as possible. And I think certainly, given that we, as Diane alluded to there, we have, I think, the first session of this committee from February to the start of July. We spent a lot of time now gathering information, meeting with groups, meeting with organisations, and I very much want from here on in to be about delivery as a committee and what we can actually do to make an impact. So anything we can be doing, because we have done a lot of work on gathering information, and I don't want it just to be every week in, week out, we're hearing all the problems. We need to now be saying, how can we enforce the solutions? So hopefully we can start to do that, and we can discuss that later in the forward work programme as well. Members, there's just two other things I wanted to raise under Chair's business that have come to my attention, and it's in my own constituency but may impact on others as well. The first one, if we could potentially write to the Minister, is in relation to the Carers Fund, which was administered through Community Foundation NI, but it was Department of Health funding to support carers. I've been made aware that it's come to an end and isn't being replaced as far as I know, and this has impacted on one service in particular that I'm aware of, because parents have contacted me, which is through Bolster in Uri, and it was a after school club for children with disabilities, and a very, very valuable service that's been running for 3 years for a relatively small amount of money for what has been delivered, but the impact of that loss is huge. And in a context of an already very limited service provision for children with disabilities, I think any further loss or reduction in services is detrimental. So if we could maybe write to the Minister around what the future plans are around the Carers Fund, if it will be replaced, and if there's anything available that could help with some of the programmes that it was used to fund, I think that would be very good. The other one is just in relation to another issue, and it's the reason I'm raising it here, members, with your indulgence, is because of the urgency. You'll all know about how important Sure Start is in our communities and early years, and in Uri, unfortunately, the early years service is due to end for some of the programmes on the 30th September. Parents have been contacted, again, parents with children with disabilities, and as you can imagine, that is a huge loss for many families. It's been a critical lifeline for many. And this is not to do with funding in this case, to my understanding, but to do with a lack of premises. And they've been trying to find a premises. So again, that they've been notified by the Trust that will come to an end on the 30th September, and for many that's a cliff edge. So it was just if we could maybe write to the Minister to see if the department and the Trust are working as hard as possible to try and find a new premises that will suit the services, because I know many families, many of whom have very limited support elsewhere, are really very anxious about this, and obviously the impact on those children will be huge. So if members are happy to do that also. Linda, were you looking to come in?
Thank you, Chair. Just in relation to the first issue that you raised around the Community Foundation funding, there was an announcement, and I don't know whether I have picked it up wrong or got it mixed up with something else, but as far as I was aware, there was an announcement that funding was actually going to be carried on, and that was made prior to recess. And if we can get some urgent response in relation to that, because the number of groups and organisations that particular fund was supporting right across every part of the north and every part of our constituencies, and all of the myriad of different people that it was helping in terms of mental health service, cancer charities, bolster the family support that you've talked about. I mean, there's a real need for family supports, as we know. Children's services is one of our committee priorities, and yet here we are having funding withdrawn from the very organisation that is supporting families to stay together so that they don't end up in the care system, or these children and families don't face the challenges that allow that to happen to them. So, I mean, I think that we need to get an urgent response in relation to that, because it was my understanding that funding was going to carry on. And I had actually been asking the question about, was it going to carry on with the same groups and organisations, because I felt that we'd already got the answer from the department. But the issue then was, where was it going? And I'm concerned that still has not been clarified. And I have put questions on this into the department, but I haven't received any responses.
So just on that, Linda, the one I'm talking about specifically is the support for carers, and it said it was the fourth and final round was announced in August 23. So I'm not too sure if that's been extended specifically, but we can certainly get the clarity on that, because I know there is funding through CFNI that does broader work as well. So it might be just a specific element of what they administer. But look, I think it's important to get the clarity around all of that as well, but given the urgency, because I think some of those programmes will have already come to an end. And as I've said numerous times about the community voluntary sector in particular, the work that they can do and the value of that for many people across the board cannot be understated, but often for very small amounts of money in the grand scheme of things. So it's very concerning when that has come to an end, although we know it's a difficult budgetary context. But thank you for that as well, Linda. Okay, members, I had nothing else under Chair's business. Under draft minutes, if I could refer you to the minutes of the meeting held on the 27th of June at page 6 of your meeting pack. Are members content with the minutes as drafted? Yeah, no, that going.
I'm sorry, I am having trouble with I was using it just before this to get it till maybe about I had sent apologies due to illness at this meeting, but there was issues that were raised that I would like a wee bit of clarity on, and I'm sorry I did have the page number kind of highlighted, but it was around our a bit on the forward work programme and our priorities. So is it best if I leave it that and deal with it in forward work programme?
Yeah, because we're going to go through it all anyway,
Okay.
at that stage, if you're happy enough.
Right, okay. Yeah.
And we'll do it then, no problem. Thanks, Nuala. Matters arising then. Item number 4, just in relation to outstanding items from the department. There's a number of things we've written to the department or the minister on over a long period of time, and we haven't got responses on. So there's a list at page 14 of your pack showing those items that are waiting a response from the department. Are we content to write then to the department just in relation to those outstanding items? I know I have a number of them, particularly around the first responders, which is growing more urgent, so happy enough with that.
Can I suggest, do you need Mover and seconder for the minutes.
We'll just, yeah. Okay, the only other thing I suppose over the summer, myself and Danny as deputy chair had had a series of meetings with various groups on the 8th of July, and I think some were other committee members attend. Was it just myself? Just the two of us. We held a number of meetings then with different representative groups who had put in requests and that we couldn't schedule into or briefings in the committee's previous sessions. So due to just how full our forward work programme was, and I think it was a very useful exercise. We also met with Haemophilia NI on the 22nd of August and received an update on the Victims Compensation Scheme, which was also very useful, given that the progress in that, and we hope to continue that contact with them. As well as that, Danny and I also were invited to attend the Northern Ireland Hospice. We both attended both the Adults Hospice and the Children's Hospice. And later in our agenda today, as part of the forward work programme, we'll be discussing some of our plans around an inquiry in terms of palliative care, so that will tie in with that. If I could also refer members to correspondence at page 17 from the Pharmacist Defence Association, who were part of the ICTU Health Committee that briefed us as well on the 8th of July. Are members content to forward the correspondence to the Assembly All-Party Group on Community Pharmacy? Yeah, okay, thank you. I think that's all. And then Stanley, did you want to come in on any of those meetings? You're happy enough? Okay, then members, item number 5 is our briefing from the Department on the draft programme for government, which you'll all be aware was published in the last week. If I could refer you to page 19 of your pack, where we have a copy of the draft. The consultation opened on the 9th of September is due to close on the 4th of November. Very welcome. So in attendance today we have Dr. Tomás Adele, who's Director of Elective Care and Cancer Policy, and Ailish McDaniel, Director of Family and Children's Policy. Just to remind everyone, we have an hour for this session because we have quite a lot to get through, and it will be covered by Hansard. So if I could just invite you to make your opening remarks. Thank you.
Thank you for your introduction, and thank you for asking us to come up here today. It's good to be here again to talk about these important things. I'm Tomás Adele. I'm the Director of Elective Care and Cancer Policy, and with me is Ailish McDaniel, who's the Director of Family and Children's Policy. The draft programme of government notes 9 priorities. Health is relevant to many of those. There is one priority that is specifically about health though, and that's cut waiting times. I will make some short opening comments on that and then hand over to Ailish, who will continue on other parts that are relevant to the department. And then of course we will take questions and discuss with you as you wish. It is accepted that our waiting times are unacceptably long and it's much worse than those in neighbouring jurisdictions. Across our 3 waiting times, there is first new outpatient appointments, diagnostics and treatment for inpatient and day case. Some patients wait many years for final outcomes. That is never okay. As noted in the draft programme, following the approval of the budget, the Department of Health has already committed investing 76 million this year for waiting list. That's a non-recurrent investment that matches additional investment of last year, but we need to make clear and recognise that it's significantly less than in the year before that. The 76 million will be used for those with red flag or time critical waits. That is those with cancer or with life, limb or sight threatening issues. 76 million is not sufficient to do any additional work on those waiting a long time. It is hence what is required just to stand still and does not represent more money than previous years. To fix waiting list demands long-term collective effort requiring sustained and substantial investment through multi-year budgets, workforce development and system-wide transformation. I've been here before and we talked about investment need. We estimate that need is 76 million this year and future years per year for red flag and time critical demand capacity gap alone. In addition to that, we require £80 million per year recurrent for wider elective care or planned care demand capacity gap and £135 million per year for up to 5 years to clear the backlog. In addition, there need to be corresponding investments across diagnostics, imaging and pathology and other areas to support the treatment of patients. The plan was required for fixing our waiting list was published in the updated Electcare framework in May. Those 10 actions, if fully implemented and funded, would address the issues and matches the investment need I just outlined. I must note that it's not all bad news though. There is much work happening within what we have. Over the last couple of years, there have been much work ongoing. Service reviews have been completed across a number of areas, leading to significant improvements in how we do things. Many decisions to improve access and outcomes have been taken. For example, moving vasectomy services from secondary care to primary care, which is both more efficient funding-wise and time management-wise, and provide good outcomes for patients. This had an impact which reduced treatment waiting lists over inpatient day case for the last 8 quarters in a row, bearing in mind that the last figures does not include all trust because of Encompass and data changes, but a sustained long-term reduction in waiting list. This is a clear sign that there is progress. Good news includes 2 dedicated day procedure centres in Lagan Valley and Oma. They've treated approximately 20,000 patients, and cataracts day procedure centres have significantly reduced the cataract waiting list. Albeit it's still long, it's significantly less than it used to be. The introduction of mega clinics to maximize patient throughput have seen almost 25,000 patients treated between January 21 and July 24. Over the last 12 months, that is March 23 to March 24, endoscopy waits have decreased significantly with 20% reduction in colonoscopy waits. This is partially because new endoscopy centres in Lagan Valley and Oma that is now fully operational. There have been significant reduction in orthopedic and general surgery waiting list, the 2 longest waiting lists we have. This is not one-off work, and this is in despite of having less waiting list funding than previous years. This is through transformation and working better. However, without recurrent investment that I noted above, it will be difficult to maintain the momentum to reduce the treatment list, and it's unlikely that other waiting lists will reduce. And this is obviously recognized in the draft program as well. With that, I would like to thank you for the opportunity to speak here and hand over to Eilish, who will continue.
Okay, I just want to say something briefly about the application of the draft programme for government to both social care and to public health. And while a very specific focus on things like mental health, child poverty and reducing health inequalities would have been welcome, it's accepted that a reduced time frame within the current mandate made it impossible to include everything we are doing. And has been, as has been the case for all other departments, it's been necessary to prioritise within the draft programme, which the Health Minister has signed off as a member of the Executive. And much of what we are trying to do within social care and in public health terms falls under the umbrella of reform and transformation of public services. And the committee is aware of ongoing reform within children's social care and adult social care and in mental health through the implementation of the mental health strategy. Other identified immediate priorities within the draft programme for government are also relevant to our social care and public health strategic and policy aims, including the delivery of more affordable childcare, more social and affordable and sustainable housing and safer communities. Better support for children and young people with special educational needs is also relevant. Research shows that 40% of health outcomes are driven by the socio-economic environment in which people live. Steps to address poverty and inequality, including enabling affordable childcare, growing the economy and increasing access to affordable housing, are of critical importance in addressing health inequality and will also impact positively on mental health. Specific reference is made in the draft PFG to the challenges within children's social care and to the ongoing reform programme within children's services. And by way of an update on that for committee, a paper is being prepared for you on the reform programme itself, but also on the Children's Services review, and that's for your meeting on the 26th of September. And that will set out what we've been able to do in reform terms to date and also provide the latest position on the Children's Services review. There is a commitment in the draft PFG to build on the Executive Strategic Framework for Public Health, Making Life Better, to tackle the wider determinants of health. There's also a commitment to redouble efforts to improve the physical and mental health outcomes of Northern Ireland's population and reduce inequalities through continued implementation of, for example, the mental health strategy. Specific reference is made to the Live Better initiative recently announced by the Health Minister, which is intended to deliver and test a new place-based approach to address health inequalities by promoting existing initiatives and programmes and delivering them intensively in communities to make a real and lasting difference. The draft programme also includes commitments to launch the Northern Ireland Food Strategy Framework and to prioritise sports and physical activity to tackle obesity. And the committee is aware that the department has worked closely with DAERA and with DFC to develop the food strategy and the sport and physical activity strategy, Active Living. And work is underway to develop a new obesity strategic framework, which will bring together obesity and prevention and obesity treatment for the first time. And the intention is to publish that new strategy, early in 2025. The domestic and sexual abuse strategy, again, is referenced in the draft PFG under Safer Communities. The strategy was developed jointly by the Departments of Health and Justice, was considered by the committee at the start of the summer and was approved by the executive last week, and launch plans are being finalised. The Health and Justice Ministers intend to launch the new strategy in the coming weeks. On childcare, Health and Social Care Trusts regulate daycare and childminding provision in Northern Ireland. Proportionate regulation will help to make childcare more affordable, and the Health Minister has committed to a review of childcare standards, starting with a consultation on a number of issues that are more pressing. That's child to staff ratios within childcare, and also health assessments on childcare staff. In relation to the priority to provide better support for children and young people with special educational needs, the Department of Health works jointly with DA on a range of SEN issues, including future planning, reform of services, transitions and the development of guidance. Allied health professionals work with children with special needs in our schools, that's both special and mainstream schools, to provide therapies in response to assessed need and to enable access to the curriculum. Our nurses play a pivotal role in working with classroom assistants to provide support for children with medical needs in the school environment. The number of children requiring support and complexity of need has increased in recent years, and the department is continuing to work with education to ensure that those needs are being met. Members will also note that under the priority to provide more social, affordable and sustainable housing, there is a reference to a joint initiative between the Department of Communities through the Housing Executive, the Department of Health and the Department of Justice to embed permanent systems change to prevent homelessness among young people coming out of care. And this is a reference to the intention to bring forward a pilot programme that will support young people leaving care and help to prevent this very vulnerable group at risk of homelessness. Finally, then, the draft PFG acknowledges the work of the Social Care Collaborative Forum, and this is a reference to the ongoing programme of work within adult social care, which has also been led by the department. The work of the Collaborative Forum sits within the department's wider transformation programme. The forum has set the future strategic vision for adult social care in Northern Ireland, is providing strategic direction and will oversee implementation of agreed actions to support improvement and transformation. The work of the Collaborative Forum is, of course, long-term, and while some measures can be put in place to alleviate immediate pressures, adult social care requires longer-term sustainable solutions and investment, which the Collaborative Forum will be seeking to address and also to influence. So in summary, members, the draft programme addresses many of the priority issues for the department in relation to social care, to mental health and public health, either tangentially through the 9 priorities identified or through reference in the body of the programme, mainly through the people mission. Okay, thank you.
Thank you both for that. And there's probably some questions that you may not be able to answer, because I appreciate you have quite specific areas of work as well. So, you know, if there are anything we need to get feedback from others in the department, that'd be useful. I suppose just to kick off from my own end, I wanted to, just in terms of waiting lists, that's probably the biggest issue for a lot of people, given the length of our waiting lists here. And it is good to hear some of the progress that has happened to date, and hopefully that will continue, given, you know, what is planned. I suppose in terms, Tomas, of the 76 million, And you'd said that would be around red flag and time critical waiting lists. Is that just for cancer, or did you say it was also?
This is red flags, time critical, and red flags, cancer, and time critical is life, limb, and sight threatening.
Okay, yes, sorry, I thought you
where,
said that. Yeah.
Where something's very serious will happen.
Very serious, yeah. So in terms of cancer waiting lists, then how much of the 76 million is allocated for that? And you know, in terms of targets and indicators on those, you know, have we got targets and what we'd like to see within that budgetary context of what we're hoping to see in terms of reductions?
So the red flag, so the 76 million is used to fund the gap in service when there's demand that outstrips capacity. We can certainly tell you in writing, probably easier to break down what's spent on last year. We're hoping to find other ways to reduce the spend by working more effectively, of course. Most of the spending is around diagnostics, imaging, diagnostics, endoscopy, and pathology. Those areas is where the spend tends to happen, and it's mostly cancers. It's not all cancer, but mostly cancer. So that's where we have a fundamental demand capacity gap in scopes, for example. It's in endoscopy, in pathology, in MRI, CT. Breakdown on exactly what they're spending on those, I would have to come back in writing for the exact breakdown.
No, and that's fair enough. And I'm actually glad you mentioned diagnostics. We recently had the Minister in Uri at Daisy Hill, and one of the issues we raised around the, which you may be aware of, the MRI scanner at Daisy Hill, which is currently rented at a very, very high cost. So is that something, not specific to Daisy Hill, by the way, but I know it's something in the region of £75,000 a month to rent it, which is a huge amount of money. So in terms of stabilising, being more cost effective, getting better value for money, we had talked to the Minister around an MRI suite, which would make more sense because in the long term, is that something that will be looked at as part of reducing wait lists, but also using our money better and on the budget better?
There is an absolute recognised need about demand capacity of an MRI. We need long-term investment in imaging. There's no discussion about that. The problem with the 76 million is that it's non-recurrent funding for this year.
Okay.
So it's not committed money for the future. That makes it difficult to make long-term investments. And fundamentally, in a lot of these areas, the workforce is the key problem. The staff simply don't exist right now, so we need to train up staff and invest for quite a few years in the future. There is work around the Imaging Academy, which I believe you heard about before, to strengthen local training in that area. That will help with that shortfall in workforce. A lot of the money that's spent on the WLA money spent, or Westminster Initiative money spent on imaging, is for additional capacity, so evening weekend work for staff or outsourcing, because we simply don't have the workforce to use it ourselves, rather than the machine, even though there's machine shortage as well.
No, and that's good. I had raised that, I think, at one of the committees as well, because I've been speaking with staff who were saying they'd be willing to do evenings, weekends, or whatever, if that could help to get people through, because there are concerns of those people who are urgent referrals maybe not being seen as quickly as they should be for imaging. So if that's something that's being looked at, the workforce challenges obviously have been mentioned in the PFG, and it was just you've mentioned there around imaging. Is there any other updates in relation to elective care workforce and planning around that?
I mean, fundamentally, we need to do things differently. So we know that we have a very skilled workforce, of course, as we all agree. But we need to think how we do things differently. So we have surgeons don't spend as much time as surgeons could do, and we don't maximise our resources.
Yes,
is what I'm trying to say. And that's not because of the doctors doing things wrong. It's because the systems don't enable them to do that. There is work to address that. We're looking at more advanced nurse practitioners, looking at nursing workforce, looking at other allied health professionals who can provide things to reduce pressures from others, to get doctors to spend more time in theatre, for example. That is ongoing in all the transformation work we're doing. That's one of the reasons why we've been able to reduce treatment waits. So the part of extra endoscopy sessions is scope-specific stuff. So surgeons don't have to do endoscopy in theatres, which sometimes is required, of course, for clinical needs, but can be quite inefficient when you have a doctor, two doctors, a surgeon and an anaesthetist. You have nursing support where it might be possible to do it with one endoscopy nurse, one endoscopy specialist. That is one reason why we managed to reduce that waiting list significantly. So that work is ongoing. That transformation work is ongoing continuously as we progress. The absence of long-term recurrent funding makes it difficult to plan long-term, but work is ongoing to maximise it as far as we can within existing budgets.
And is the funding then, is the allocation of money through the normal monitoring round process, or is there any other process for allocating funding?
76 million.
Yeah.
The 76 million is allocated out to trust when they require it through the department, through the
Okay.
normal channels, and it's what is procured externally is procured through normal procurement processes.
Okay, no, that's fair enough. The other thing, just in terms of the elective care, and obviously you had mentioned around orthopaedic waiting lists, probably some of the biggest, and we had raised this with the Minister. Again, I'm not being parochial, it's just because it's the one that I'm aware of, is obviously the elective overnight hub in Newry and Daisy Hill. And we had asked, was there any potential to start having orthopaedic procedures carried out there? Is that something you're looking at across the board, about expanding the ability to provide orthopaedic procedures through some of the elective hubs that aren't currently providing it, obviously?
We need to make sure we maximise the resource to get the best out of the sites and staff that we have. The problems with so I'm not. It's consideration, absolutely. So I'm not saying no, but the challenge we have, if you spread the workforce too thin, it's difficult to get effective throughput of services. I'm not saying that's the reason why we can't do orthopaedic in Daisy Hill, but that's one of the things we need to consider. It might be the most effective way is where we get the staff to be happy to work where they are in an effective way.
Yeah.
In the Southern Trust, particularly in Craigavon, the fracture pressures means that the orthopaedics is very difficult. Additional theatre sessions in Daisy Hill wouldn't remove the fracture pressures in Craigavon. So that's the unscheduled, so that's people breaking bones, which is the same surgeons, so the same clinical staff who deal with both. That increase in fractures makes it very difficult to deliver an effective orthopaedic service in Southern Trust. So it's not the site, it's not the theatre room, it's the doctor, it's a number of doctors doing that kind of work.
And will that then, I suppose, inform part of the workforce planning around elective care then? That's something that could be looked at, because orthopaedics obviously are probably one of the biggest issues, and as you well know, I'm sure that as people are on that waiting list longer, then by the time they're actually saying they maybe need another knee done or another hip done or something because of the pressure on their joints.
Well, absolutely, but it's also about thinking differently. So in Musgrave Park, in the Duke of Connacht unit and their procedure unit, we now have nurse-led procedures for, say, carpal tunnel, which is reducing pressures and therefore helping reduce the waiting list regionally. So it's about thinking differently. Can we pool the resources to focus on some body parts in some areas to make sure people get treated quicker? And we're not talking patients travelling for everyday stuff, but for the one-off surgery. If that gets better throughput of patients, that means they have to wait shorter time. But that's ongoing work that's bread and butter what we do to try to make that kind of transformation happening.
Yeah. My last point then, in relation to that, you'll not be surprised in raising this then, is if workforce can be the problem in some cases, particularly around orthopaedics, is there any scope then again about reinstating the cross-border directive?
I mean, it's a funding issue.
But it's not. It hasn't been funded. There's nothing within this existing budget.
No, there's nothing within the existing budget. So the WLI funding or the waiting list funding we have this year, it's only for red flag and time critical.
Okay.
The cross-border scheme are for people who are urgent or routine waiters, mostly for orthopaedics. They're not cancer or time critical patients.
Yeah, no, and that's what I mean. It's probably the biggest query we get through all of our offices, I would imagine, because people would like to be, if they can go and get it done quickly and be reimbursed for it, then they're willing to do that, you know. And it's not for everybody, but it would certainly help with some of those orthopaedic waiting lists. I think we've seen how it has in the past, and we would suppose I would urge that if there is any money comes available that could be used to just try and offset that on a temporary basis. I mean, I don't want us to be, this is a long-term solution. We'd rather have our own capacity, but given the waiting lists, I think it's something we would hope that would be kept as an option. There's just two very quick points then as well. Obviously, the reconfiguration, transformation reconfiguration is mentioned in the PFG as well. It was my understanding that we would have seen the blueprint early July, and committee still hasn't seen that. I do know it has been out for consultation with the trusts, but I think it would be useful if we were able to see that, or if you could provide a timeline and when we're likely to get an update on it, because it is very important. It's something that we all have been asking for some time. The Minister did say that he would have it to us.
I mean, I know that there's a lot of work ongoing in this in that area, as you know. I don't have a timeline for that, but we'll get back to you on that, on the
Okay.
timeline. Sorry, I just don't.
No, that's, and I appreciate that's probably not your area of work, maybe, Tomas, but if we can get an update on that as soon as possible, I think it would be very good, because we have been asking for some time. And my last issue is that we've been doing a series of meetings with various sectors in the health service, and we had been working with some of the palliative care providers, and it had been raised with us that they were very disappointed that that wasn't a PFG priority in terms of dignity and dying and bereavement as part of this. Are you aware of any discussions around that as a priority for PFG, or any other priorities that the Minister had suggested to be taken forward outside of what is in the programme for government?
There's a lot of work in the department that's not covered by the PFG. There's a lot of areas where there is a lot of work ongoing that's priority for the department. That includes a palliative care area. It's just because it's not in PFG does not mean it's not important work, then it's done. And there is people dedicated in the department to do this work that is taken forward. Palliative care. I've got the assurance latest yesterday when I was speaking to those people. They're happy to come and provide a specific briefing to you if that's helpful. But it is a key part of the department's overall work is to make sure that we have a good palliative care services that we deal with bereavements, the people who are bereaved in general.
Well, we maybe follow up on that as well, because it is a priority for the committee as well, so it'd be good to get an understanding on that as well. No, thank you, Tomas, thank you, Eilish. I have Diane.
Yes, thank you, Chair, and thank you for the presentation. There's a couple of things that I kind of just want to follow up on, and then I'll ask a couple of more substantial questions. I asked the previous Health Minister about this issue of transformation and reform in April, and he said he'd have it in 2 weeks' time. The current Health Minister promised us he would have it in July, and I think if there's a message that goes forward from this committee, it is that we do need to see it. I understand why trusts, etc., would have a view on it, but at the end of the day, there will have to be a general discussion on this issue. And I do think it is important in terms of transformation and reform that it is done as soon as possible. And I understand that there's reasons why you want to do as much background conversations around it as possible, but I still think it is really, really important. Can I say also, I do welcome the focus on health waiting lists, because if my research is right, we have not met a target for that since about 2014, maybe even earlier. So it is a huge issue, and I think everybody around this table will understand and will have people in their constituency who present to them in pain and in difficulty in relation to. So I do welcome that. I think that that's really important, and I know that there's a lot of other things that are really important as well that the department is doing, but the executive priority on waiting lists is significant and is important, and I do think that is right. Can I ask you first of all about the Reform and Transformation Unit and how you understand that might work, how health will interact with that Reform and Transformation Unit, whether you will have bids for that Reform and Transformation Unit, and if so, can you enlighten us as to what you're actually going to do that? Because it seems it's an important part of the discussion, but it's kind of up in the air and not that tied down.
Thank you very much. Reform and transformation is a huge part of everything we do, and it's been for quite a long time. So we welcome a Reform and Transformation Unit for across the whole civil service. That's a good thing. There is a transformation funding program or program funding. The department has a number of bids in that process.
Right.
We have a large program which is primary care MDTs, which is a bid for significant funding for that.
Primary care.
For primary care, yes. so that I'm sure you're all fully aware of the primary care MDs, but that's to provide services close to where people live, to therefore provide more effective services, better patient outcomes, which will help improve health services in general, but fundamentally provides better patient outcomes with closer care to patients. And that's a fundamental reorientation of how services are delivered to focus on the community. And that matches other transformative work that's ongoing. So, for example, moving vasectomies. So speaking of waiting specific, that's moving vasectomies to primary care because it's better for patients and also a more effective way of doing things. Primary care MDTs is the future for primary care. There's also 3 digital landscape review bids. So the 3 digital bids. They're focusing around using artificial intelligence to improve productivity, alongside the new data systems and Encompass Epic system that is being rolled out across the health service. It's about making sure that the public funded systems and the independent sector systems can speak to make sure that patient safety, so patients being treated in private sector that their health records can be transferred across, because also that could lead to less favourable outcomes if people don't know what's happening with patients across both sectors. And it's about cybersecurity and a cybersecurity strategy, and they want to help invest in delivery of that, to fixing funding to improve the way the sector protects information for our population and ensure privacy across the HSE. That's the 3 digital bids that are currently in the process. The funding is a significant funding across each year in terms of new ways of doing things. It's in the 40s of millions a year, as you know. In the terms of health,
Can you tell us what the bids are and
how big they are?
Yeah.
I don't have that information. I have to come back to you on the numbers.
Okay.
But the overall funding pot across the whole society is significant. But in terms of health, if you're thinking that, if you know what our investment needs are, what the waiting list needs are, the overall funding available in the mid-40s of million per year is important, but not sufficient to do significant health transformation. That's something that's recognized.
I think every department was able to submit, I think, 2 what were called large bids and I think 4 small bids. A large bid, I think, was defined as an amount over £10 million.
Can I ask then what the rationale was for submitting bids around primary care, but not bids around capital and imaging and diagnostic, where you constantly tell us, Thomas, in the committee, that is where the shortfall is?
They serve different purposes. Primary care transformation, MDT, is a transformational way of changing how we do health service. It is truly shifting the focus from hospitals to community, closer care to community, to, in the longer term, obviously prevent patients needing hospital care at all. Mm-hmm. That is the right thing to do long term. It doesn't fix our short-term problems, but it fixes long term problems. That's a good, sound, transformational investment. A lot of the work around imaging and diagnostics is increased capacity. It's transformation as well, but it's not majorly transformational. It's a shortfall in investment over a number of years. There is a demand capacity gap. That doesn't match the requirements of a transformation funding bid. So it's different. Okay. It's different kind of investment. Not saying that both are equally important. Long term for our population's health, primary care MDTs will undoubtedly have huge impact.
So, you refer to the amount of time that consultant surgeons, for example, spend in theatre, and I have asked questions around this, and in some instances, in some trusts, and of course it varies across trusts, that is as low as 20% of their time is actually spent in theatre. What do you think needs to happen to increase that productivity gap? By the way, I don't know the reasons for the 20%, and I don't know the reasons for the variation across trusts, because I think that is part of the structural inequalities that we currently have in the health service that are really, really difficult to explain to our constituents, particularly those of us who have constituents that border a number of trusts. what is happening? Because I think that there are fundamental things that we need to look at around the productivity and so on. And by the way, when I asked that question, I did get a note from the Royal College which said, thank you for asking that question, because we do need to get to the bottom of the issues, whether that's lack of theatre time, lack of staff to staff theatre, lack of imaging to proceed, you know, too much time spent in consultations. You know, I think everybody is frustrated.
I would recognise that everyone is frustrated. I think that's everyone is frustrated. We want to do more with the resource we have. There are a number of issues which makes it difficult. So with a couple of, upon a few things. The first is the increase in unscheduled pressures. So the increase in unscheduled pressures on the same sites as planned or scheduled care makes it difficult to effectively deliver and plan elective care. If someone turns up in ED requiring surgery, they will have priority. So that is difficulties. There's been a significant increase, or there's a year-on-year increase, as you know, on those pressures, and there hasn't been a matching funding increase, which leads a funding or an investment gap in that space. The creation of elective care centres separating elective planned care and the unscheduled care is a huge step in the right direction. We're protecting time. So we know that last winter, for example, there was a much lower short downturn in elective surgery than had been in previous years because of the separation. And that is separation of service. It doesn't necessarily have to be separation of physical sites. It's a clear distinction in what the service being delivered in what room essentially. It can be in the same physical building. And that is a significant aspect. Another aspect is the lack of theatre nursing. And that's a real difficulties. If you don't have sufficient theatre nursing, you obviously can't deliver theatres. Theatre nursing is a difficult speciality. It's difficult work, it's heavy work, it's challenging. Obviously we have a lot of good staff that are willing to do that, but it's not something you can just walk into. It requires training, it requires settling in, and that process can take quite a long time. So even after a decision to increase theatre nurses, it can take 6-12 months before those people to start are actually able to do that, even though there's no difference in grading, banding, or formal qualification. In addition to that, we have surgeons doing too much and not surgery, too much other stuff. So we need other staff to support surgeons to not have to do things like some routine assessments, patient follow-up that can be initiated by the patient. So there's a big program work around patient-initiated follow-up to drive that not everyone has to see a consultant after surgery. It can be that if you have a problem, you phone the consultant. So trusting our population, where it's appropriate to do so. We should always trust population, but where it's appropriate, giving that to the patient that actually you don't need to come back unless you need to come back. And that is ongoing, but it's not quick fixes. It takes time to build that through, because as soon as you release one surgeon, you suddenly need a whole new theatre team in theatres, you need nurses, you need everything building up as well. So there's a lot of things that need to fit in place at the same time for this to work. But this is why we're seeing a reduction in treatment waits, because this work is ongoing. So there are improvements, but they're slow. But we're in a better place now than we were 2 years ago.
Okay, thank you, Thomas. Linda, online, sorry.
Thank you, Chair, and thank you, Thomas and Irish. I could ask questions on this stuff all day, but I have a couple that I just want to highlight today. First of all, you talk about putting more into the primary care, and I absolutely support that all day, every day. Prevention, keeping people well, is much better than fixing people when they're already sick. So I am 100% behind that. But when we talk about the vasectomy services being moved out into the GPs, actually what happened was they were taken off the GPs and then sent back out there again, which I welcome. But the reality is that was cut. That was one of the first things to be cut whenever funding cuts had to be made. So if we're serious about this, we need to genuinely put our money where our mouth is and invest in primary care and look at that, as you've said, as our long-term plan. And I think that there is there are many other services that GPs were providing around gynae care, around specialist diabetic services. There was, and I know that Liz met with a group in the Southern Trust, around services that were provided to support people who have cardiac issues. So I think that all of those things are either have had funding withdrawn, or are not being funded, and are being brought back in then to either brought back in the hospital service, or people end up needing hospital care because they're not getting the service. So I mean, I think that we need to be totally honest about what we're doing as the starting point. Just be honest about it. You know, we don't fund our GP services anywhere near where they need to be funded to. So I suppose one of the questions that I want to ask is, if we're going to give services and we're going to say we're going to invest in primary care, that's where we want people to be dealt with, are we going to fund them to do that? Are we going to actually give them the funding that will allow them to do it? That's my first question. The second one is, and this is a kind of an aside, but it's around funding as well. So violence against women and girls is a priority in the PFG. The funding for women's aid has been severely reduced, and some of that, much of it comes from health. And we need to look at that, because if we're going to address violence against women and girls, that is just one. I mean, Nexus is another that have had their funding and their ability to help people severely reduced. So we need to fund the community and voluntary sector. We need to fund primary care sector, because that is where we do the preventative and early intervention work. And that's the reality of it. I understand the position you're in and having to deal with the waiting list that you have right now. But long term, if people are not seeing their GP, then they're ending up very, very sick and ending up in hospital, and very often being diagnosed too late. And we know the statistics around people being diagnosed in A&Es. And I'm sure many of us on this meeting have had people we know, or family members or loved ones, that were in that very circumstance. So I suppose I'm gonna stick to those for now. I have a lot of questions around children's services, but I think it's probably for a specific session, to be honest, rather than taking up this whole session with it. And Chair, if I can finally just say, just in case I have to drop off before the item in relation to the committee motion, I know it's going to be in close process, so I'm not going into any detail, but I have a slight change of wording that I'll send to you if you don't mind.
No problem, Linda, thank you.
Thank you.
Thank you very much. In terms of vasectomies and the funding of primary care, the primary care elective was funded non-recurrently through waiting list initiatives. So there was a year-on-year or quarter-by-quarter % funding for the primary care elective. In 21-22, we spent 91.5 million on double line total, including the primary care element. In 22-23, 96 million. In 23-24, that was 70 million. There was significant drop in funding available for waiting list initiatives. That forced us to stop everything that was not red flag and time critical. That includes the primary care elective. So while it in practice it was a cut, it wasn't a cut as such, it was a stopping of new funding. We didn't have the non-recurrent fundings to allocate to primary care elective for that purpose. What we then did about vasectomies was moving the service from secondary care to primary care. So we defunded the service in secondary care and moved the funding to primary care. So the money followed this decision followed the decision to move it to primary care. So that is a substantive recurrent investment in primary care funded through not providing it in secondary care. So that's how we make it sustainable and long term. That's how we provide proper investment, or one way we can do proper investment in primary care to ensure they deliver. And it's important to note for vasectomies specifically, it's patients are satisfied with the outcome. We have no patient safety or outcomes concerns, and the service in primary care is about 1/3 cheaper per patient than in secondary care. So we get more for money, better outcomes, and better patient satisfaction, which is a win-win for everyone. So that's what we need to do. Vasectomies is quite a small, contained provision. It's quite easy to move. Other areas are much more complex because interdependencies and the effect that have on ability to deliver other services in healthcare. But the concept of wanting to do this across other areas is absolutely there. That's what we want to do long term. It's just not easy, not to have unintended consequences. For example, to reduce number of doctors delivering something in secondary care, that might have an impact on the ability to deliver emergency care, which obviously we don't want that impact. So it's about finding the right things and making sure it's sustainable. But it has to be sustainable, otherwise it's not meaningful, and I fully agree with that.
So on ending violence against women and girls, I mean, that was one transformation bid that we submitted jointly with the Department of Justice, specifically relating to the implementation of the domestic and sexual abuse strategy. I think, Linda, the Minister is on record as being disappointed at having to cut core grant, and it was cut by half this year and last year. I think Women's Aid received something like £73,000. The Women's Aid, Federation received £73,000 this year. That was in addition to the £750,000 that Health and Social Care Trusts invest in Women's Aid's projects. We are starting a process of designing a new core grant scheme, Linda, and we're working with NICFA on that. So there are a couple of workshops being organised, and I think they start on the 20th of September, and that's working jointly with the voluntary and community sector on the design of a new scheme. We're also currently looking at putting in place what we're calling a small grant scheme under the domestic and sexual abuse strategy, and that would be targeted at the voluntary and community sector. It would be a relatively small amount of money, but we will seek bids from the sector to support the implementation of the domestic and sexual abuse strategy.
Yeah. Happy enough, Linda?
Thank you. Yeah, thank you.
Thank you. Danny?
Thank you, Chair. Thank you for that presentation. I have a couple of questions. I want just first to say about the vasectomies decision. I think it was fantastic and it was very welcomed. Certainly I know a lot of families in my constituency that welcomed that decision, moving it back into GPs. They would have had to go to the private sector effectively, rather than sit on a long waiting list on the hospital waiting list. So it is absolutely important to them that they're able to use that as being able to help them with, you know, the size of their family and things like that. So that was a very, very good decision. As you say, saves money as well. So it's a very good example of how we can make those changes. In the programme for government, I want to emphasise the need for transformation and reconfiguration in it. Certainly that's obviously all over it, but in health. It's good to see, but we do need to ensure that political will and leadership is there when these proposals are made. It's recognised, I think it was referred by both of you, that we have a truncated mandate and we have only 3 years in which to do this, so obviously we're limited by that. One of the things, Thomas, you had raised was the multi-year budgets. I'm just wondering, what is the scale of the savings that could be made with multi-year budgets, and do we have any possibility of being able to do that within this truncated mandate?
So the challenge for us when it comes to healthcare services is that almost all cost is people. Mm-hmm. To be effective in investment and effective delivery of service, we need to know how much money we have, so otherwise we can't invest recurring in people. So for example, the £76 million we're spending this year on waiting initiatives is non-recurrent. So we can't recruit more staff to deliver services without funding. That is not an efficient way of doing things. We can't plan service in future well. Multi-year budgets, whatever that budget is, will allow us to plan. We know what can happen next year, so we know how we can plan services, we know who we can recruit, and where we need to use other independent sector companies, providers, we can make longer term contracts. That is more effective both in terms of planning, but more effective in terms of value for money. And it goes without saying that if you make a 3-month contract with a provider, it costs more per unit than if you do make a 3-year contract with a provider. So multi-year budgets is essential for us to be able to plan and to be able to transform effectively.
Do we have the ability for that to happen over the next 2 years, over the shortened mandate? Is there room, and what would be the scale of the savings?
It's not possible for me to determine savings. We don't have enough funding to deliver what we want to deliver. To fix waiting list, we can't save money. We need to invest more money. So the question for me would be, if we invest in a waiting list, how much improvement can we make in a waiting list? If we want to save money, multi-year budgets, we can reduce what we do in waiting list and accept longer waiting list. It's not possible to spend less and reduce waiting list. That's incompatible.
With the 76 million that is being spent on the red flags cancer, mostly cancer diagnostics and things. Given this is non-recurrent, does that mean that a lot of that is going to be independent sector bought in? Is a lot of that agency spend then? Is that...
There is mixtures. There's additional work within the HSE, so evening, weekend work, so essentially overtime and similar work. There's also independent sector spend, and some of that is simply more capacity where we don't have enough. So if we don't have enough endoscopy provisions and we need endoscopy provisions for our cancer patients, we then purchase it from the red flag or from the independent sector. There's some quite small amounts, but some of that is about where we simply don't have the provisions. We have never invested a service, but we need to deliver that service. And there are some things around some time critical heart surgery, for example, that we just don't do in the health service, but that we need to deliver. So we purchase that service from somewhere else. And there are a few things like that, but that's the kind of things we spend the money on.
What's the rough sort of split of that 76?
I can give it a split for last year. I would have to come back to you in writing on last year. Obviously, we are endeavouring to do as much as possible we can in-house.
Okay.
So a planned split for this year would be difficult to provide because we continue trying to do things better and trying to do things more effectively. But I can come back to you on split last year.
The lack of multi-year budgeting means that you're basically forced into spending more on agency on these short-term contracts.
Yes.
Yeah. Sorry, just one of the things that came up was the development of elected care centres, rapid diagnostic centres, service reviews and mega clinics. Now this obviously is great news, and there was good news in that front that we are bringing these lists down. I'm just curious, with the ongoing engagement that you're having with officials and medical professionals such as Royal College of Surgeons, are you getting any feedback? What feedback have you had from the likes of the Royal College of Surgeons and other organisations, and how has that helped to improve efficiency?
So, and someone's right when I say this, but I'm a civil servant. I don't know how to deliver effective healthcare services. Of course, in a civil servant, I need to seek advice from others, Royal Colleges and other professional bodies and clinicians. That's how we get the right answers. I mean, quite simply, surgeons know how to do surgery. By speaking to surgeons and speaking to nurses, speaking to other health professionals and the service leader managers, and how we deliver the best service is how we get the best service. That's why we have elective care centres. So the current transformation in elective care, which is quite far gone, is there purely because of the engagement we have with professionals. I meet the Royal College surgeons, or there's obviously 4 of them, but I meet Royal Colleges and professional bodies and professionals all the time. I met Royal College Surgeons England earlier on this week, and had engagement with clinicians this morning. This is bread and butter what we do, because that's what we need to ensure we do the right things. The feedback about elective care centres is positive. We see that in a number of ways that surgeons like working in them because they get to operate. That's what they want to do. That's what they're good at. And nursing staff, they just like working in those places. Then theatre nurses want to be theatre nurses, and they get to be theatre nurses in elective care centres. Some nurses obviously like unplanned things. They want ED, they want that kind of environment. Some people want to work in medical wards, some want to work in surgical wards. If you work in surgical wards or surgery in an elective care centre, you know what you get, and you get what you want. We therefore see that the vacancy rates are relatively low in those sites. It's a good place to work, and that's really good feedback that this is actually working, apart from the fact that patient outcomes are actually really good, and throughput is higher.
Absolutely, that's to be welcomed. And just with the blueprint that we still haven't seen, I know we've requested it a couple of times from 2 different ministers now. Have you had feedback from the likes of the Royal College of Surgeons and other organisations on the blueprint of acute services?
Absolutely. I mean, when it comes to elective care services or planned service which we have, the whole concept around the reconfiguration framework is based on the work that is already ongoing. It is based on the elective care centres having different levels of elective care centres, like deputy centres, elective United States centres, complex elective care centres. That is developed with the Royal Colleges and others. That's their involvement is bread and butter of what we do in those areas. So yes, absolutely, we're involved all those bodies.
You're saying there has been a lot of consultation. That's your
absolutely. I mean, and we should remember that some of these things are put together from all other work streams that are happening. So the elective care work that's featuring in the reconfiguration framework is not new necessarily. It's reform work that's already ongoing. That's the Royal Colleges have been key in that work. I mean, quite frankly, we wouldn't have been able to do it without them. They are the experts. We need to use the experts.
Thank you.
Thank you, Nuala.
Thank you, and thank you for the presentation. Like Linda, I will reserve my comments around the children's services and for the 26th, probably no point to in rehashing them, but just in terms of an update at that meeting, we would be keen as a committee to hear about, whilst political decisions or policy decisions still need to be made, about what can and has been implemented up until now, is following the review. I want to touch base on a few of the issues that were just discussed, and particularly around that 76 million. And it's good to hear that the department, and rightly so, does work with clinicians, etc. And that is important. They need to know better in ways of treating people and what's best. But for people out there who are on a waiting list to be seen, who are either red flag or time critical, as you said, Tomas, what does it look like in the decision making process as to who gets that money spent on them for the treatment that is time critical? So at what point through, the department, SPPG, the trusts, who makes the decision as to where the money is spent, not on the red flag but on the time critical treatment? Because I'm sure that there will be people who think, well, everything is time critical to them because they've been waiting so long. So where is the actual decision made, at what point and through what mechanism, as to what is time critical, because there's so many areas and waiting lists?
So I mean, the time critical aspect is quite limited. So it's life, limb and sight. So it's quite specific. That's a clinical decision, this clinical decision, and they are prioritized for treatment or for assessment diagnostics as part of clinical prioritization.
But are they just those decisions though? Are they made across trusts? Are they made in each trust silo? Because I know that there are, with the surgical hubs and the aim to try and protect sites to carry out X treatment, there's still some that are across the trusts. So is it through the trusts or higher up? Like, where is the clinical decision made?
So the clinical decision, whether someone is time critical, is made by clinicians. That is clinical decision. If the trust can't deliver the time critical, the trust can then seek funding to deliver additional work. But as a trust, as a corporate body, seeking and that funding is then provided the department through SPPG on that. It's important to note that not all sites are suitable for all types of surgery. So a day procedure site would probably not do much time critical work because in general time critical patients are not suitable for day procedures. Yeah. So it's not. Some of the regional sites are not suitable for that kind of work at all, and that's.
So essentially, those clinicians will make those decisions, and it will be because the money's going to run out. That money will run out at some point, but the decisions keep being made, because what I'm trying to kind of ascertain here is we've discussed that and we recognise that there isn't an endless cache of money at the minute to tackle, so it has to be very specific. So at what point, whenever they keep saying this is time critical, does say actually that's it, or does it keep going in terms of that clinical decision?
Someone who's time critical patients will get treated.
Okay.
If we can't treat them within that 76 million, eventually something else will stop to provide treatment for those patients. There's patients who will either die, lose a limb or lose their sight if they don't get treated. They will always get treated. And it's the same with our cancer patients. We know cancer waiting lists are too long, so I'm not trying to justify anything, but actually treatment for cancers start fairly promptly. So the 31-day target, so the between decision treatment is sitting around 90%. While it's not as good as we want it to be, people who have a cancer diagnosis in general get treatment fairly quickly. They get a long time before they get diagnosis, and it's unacceptable that it's not higher than 90%. But the treatment bit tend to happen fairly rapidly. Because those patients will always come at the top of the pile when it comes to clinical prioritization. It's other patients who will suffer. So if we run out of 76 million, the effect will not be on the time critical patients immediately. It'll be on everyone else, but they become much less efficient because it wouldn't be stopping £1 a patient to get £1 a patient there. It was many pounds patients to get £1 a patient in that pile, because those treatment areas are not suitable for those patients, so it's moving resource around. But
It's almost as if the time critical patients will always get seen, and I'm sure that's and hopefully that is reassuring for anyone who is concerned that time critical patients will always get seen, so they're not on like a waiting list per se, they will just always be seen.
I mean, and this is the thing that we always want, there will always be some waiting lists, and we need some waiting lists for management of patient and management of procedures to make sure that we have efficient procedures. So the question how long is appropriate for time critical, what's appropriate is very short time. But I mean, that is patients who are at risk of dying, or risk of losing a sight, risk of losing a limb. That's when we need to treat them quickly. And exactly how quick that is, that depends on case by case, of course. So some time critical is not time critical as in it's done tomorrow. It can be done within quite a long period of time, but before a certain cutoff point. And if you're the day before the cutoff point, it's time critical by the next day. It's
just it seems to me then, if it's red flag cancer patients rightly show in time critical, it's not actual waiting lists. Or, you know, if you get what I'm trying to actually get at here, is that absolutely priorities have to be made. And you're right, time critical, of course, and red flag cancer patients, for example. But you can't really sell that as that's tackling waiting lists if actually that's not the waiting list. The waiting lists are everything else. So I think I think whilst we rightly should reflect and welcome the progress that is made, especially with the surgical hubs, and we should acknowledge that progress is being made, that this money is not actually for waiting lists then, is it? You know, because I know that those people who are waiting for time critical, they will always get seen. So it's what is the plan for everyone else? You know, it's the plan for everyone else, and notwithstanding the argument about the budget, I understand that. I completely understand that, but it's just the reality of it's not really tackling what everyone sees as a waiting list. But I don't expect you to have all the answers. I
understand what you're saying, and I fully can accept that's part of the truth. I mean, that's as I said when I am opening remarks, that the 76 million does not allow us to treat people who are waiting a long time, treat more patients who are waiting a long time. If we didn't spend money on the time critical patients, apart from the outcome of those patients, that would mean that those patients will then push out others who are currently being treated. So if it didn't spend 76 million, waiting lists would increase significantly. Fundamentally, when the person is on the operating table, it's a patient, whoever they are, and the time in the space in theatre is the same space, same physical space, whether it's time critical patients or waiting 5 years. So if it didn't have the additional money, the overall waiting list would increase, and they would get worse than this now. So it is tackling waiting lists, but it's not tackling the long waiters, if that makes sense.
No, and just in terms of the waiting lists in general within the programme for government, and the importance of tackling that, I just have a query around specifically when it comes to children's health, and how that fits in, and if we think that there is the same level of problem within children's waiting list, and is there going to be a specific element to that? The one most notably I can think of at the minute is the waiting list for PEG tube surgeries for children, for example, that have there are a group of parents, a very small number across Northern Ireland, who have been lobbying quite heavily on the issue. And that is just one example, but it actually brings to light the issue that there's waiting lists for adults and there's waiting lists for children. So what is the differentiation between the two within the department and SPPG in terms of actually allocating funds to tackle that?
So, well, I'm going to ask you slightly differently, bear with me. I will answer what I think we want to hear, in the sense that when it comes to surgery, fundamentally we don't disaggregate between adult and children. So we want to see surgery for everyone. And the normal age bracket we think of children doesn't necessarily always apply. So what is a child is not necessarily a child in a theatre. Saying that there is, I mean, Daisy Hill provides both elective overnight stay centres for adults and elective overnight stay centres for children. in our work to transform services, we look at both. We don't distinguish in that sense. There's slightly different answers, but fundamentally the problem is the same. We don't have enough capacity to meet demand. The transformation is the same. While there might be a different surgeon, the concept that a surgeon don't spend enough time in theatre is the same. It's the same. Theatre nursing is very similar. Granted, it's different anaesthetics, but it's the same fundamental problem. So when we tackle waiting list, we tackle waiting list across adult and children. We see it as one problem because fundamentally the underlying issue is the same across both. We obviously deal with individual issues separately. So for example, we're currently finalising a paediatric orthopaedic review, just looking at how we can improve paediatric orthopaedic surgery waiting list. There's been significant work on paediatric ENT waiting list, and it's particularly a difficult list for those people with tonsils especially, where there's been excellent work to consider if children actually need surgery, and a significant number of children were determined not needing surgery. It's in a better patient outcomes of not operating. And that's not because we want to disregard those children, but because thinking what's actually best for the child. So there's a lot of work ongoing on paediatric surgery as well, but it's not a clear separation, because it's fundamentally the same transformation work required to improve surgery across the board, both in adult and children. Does that answer your question?
No, it does. It does. Yep, it does. It's just that we do, in terms of our engagement with the sector, in particular those within the children's sector, children's health sector, there is a concern that the commissioning work is not seen as a separate piece, and there could be efficiencies. But I think that's something worth exploring further at a later date. But I think that answer that you give is, you did answer the question. To be fair, I don't have any other questions other than an observation in terms of the working collaboratively across the departments. We have heard from many departments and in all the different committees about working together. So I think one of the key elements of the PFG is about that collaborative working, and perhaps another piece on the 26th of September we could have that the reflections on the Children's Cooperations Act, Children's Services Cooperations Act, and actually any strengthening of that or lessons from that, particularly because the PFG does actually talk about that working collaboratively.
Thank you, Nuala. Orlia?
Yes, thank you. I'll just ask all my questions at once because I know we're about half an hour over time. Tomas, it was just to come back to the primary care issue. So I know obviously, as you were saying, it was hard to try and condense the programme for government in terms of priorities because there's so much that you are working on and dealing with. But in the document that we do have, there is quite a heavy emphasis on the importance of primary care, and it's referenced a few times around how we need to invest in primary care, how we need to continue with the long-term journey of long-term reform, which includes how primary care can impact and help in terms of tackling health inequalities and as you had says, preventing people having to go into emergency departments or into hospitals. So see the 76 million then that's been set aside or that's been used for the urgent waiting lists and time critical. Given the emphasis on primary care, is there any planned additional investment for primary care because of the emphasis and the importance that obviously you recognise in terms of the service that it provides? So that's my first question, if there is any other targeted or planned additional investment. And I know you have mentioned, Diane, around the transformation bids for the multidisciplinary teams. So I'm assuming maybe that's one of your bids for primary care. Does that transformation bid include extending the MDTs out to all the GP Federation areas? Because at the minute, obviously, it's only operational in 3 out of the 12. My second question is, sorry, I covered 2 questions in the one there. My third question is around the so you were using the example of the vasectomy service, which was transferred from secondary to primary care. And obviously, yes, there is a lot of work in transferring some of those services to primary care, but I was just wondering if there is any scope and exercises underway at present to maybe look into if there is other services in secondary care that yous might be looking into or forward planning to hopefully maybe move into primary care, just if any of that works ongoing. And then my final question is to Ailish. Ailish, you had mentioned earlier just around the design of the new core grant scheme. So is that the overall core grant scheme for the Department of Health? Just as you were speaking there, so you mentioned there was an event on the 20th of September with the community and voluntary sector, and instantly what came to mind, obviously it's within my own remit and portfolio in terms of mental health and suicide prevention, but we've raised and the committee's raised with the Minister on multiple occasions. I know there's so many groups that don't qualify for that core grant funding at present, but in terms of the mental health, there was the Well group from County Down that we wrote to the Minister about. Now, that was Robin Swan, I think, we wrote to about previously. The Niamh Louise Foundation in Dungannon, the West Wellbeing in West Belfast. There is a lot of amazing community groups who aren't getting any core grant funding from the department, but who are literally, in terms of the work that they're doing for suicide prevention in local communities, saving lives day and daily, they're just doing powerful work. So I wanted to know, that session on the 20th, was the likes of those groups, did they receive communication that there was this event in terms of a new core grant funding scheme? Because it's really important if the department is, taking a refresh look at how that scheme is distributed, that everyone needs to be in the room who has been part of that lobby in terms of trying to get more funds, which I know are really tight at the minute right across, but it's just to see how you've worked out that process.
Do you want me to take that first then, and then
Yes.
come back
Thank
to
you.
Tomas? So, I mean, you're quite right that the scheme is closed. The current scheme is closed in the sense that 62 organisations have been receiving core grant from the department for some considerable period of time, and we did attempt to open the scheme up a number of years ago, and that didn't go quite according to plan. So the plan now is, by way of this redesign process, is to create another open scheme, hopefully accepting applications from April of next year. The work that we're doing is through NICFA. So NICFA is facilitating the sessions for us. Certainly I attended a session a number of weeks ago, maybe a month ago, and there was great representation from the voluntary and community sector at that session, and that was about designing the process around redesign, if that makes sense to you.
Yep.
So my expectation is that we will have good representation at those workshops. Because of the involvement of NICFA, and NICFA has been communicating with its members. If there are specific organisations that you think would benefit from an invitation to those sessions, very happy to get the details from you. We can ensure that they're at least invited.
Brilliant. Thanks very much, Ailish.
So, when it comes to the waiting list initiative funding, so the 76 million, it's for red flag, so it's cancer and time critical patients. In general, they're not clinically appropriate to treat those kind of patients in primary care, because of the clinical demands or needs they have. As a concept, if it could move things to primary care, I would do so in a heartbeat. It's a right way to treat patients. Moving things towards the community is undoubtedly better for patients in general, provides better value for money, and is something that clinicians like, both in secondary care, primary care, and that the public likes. That we want to continue to work. Vasectomy was a start. It's not the end. It was one of the few simple things to move. Other things becomes far more complex, and the process behind on how we do it and what volumes and what can be delivered in primary care without having unintended consequences on other things. It's not an easy process. It just takes time to work out what can happen and how to happen. But I would certainly hope to be in a position that we can announce other things in the future. I don't want to put a timeline on it though, because it is not simple. But the unsimple answer is yes, we're working on that in the background. When it comes to MDTs, the funding, transformation funding, will further roll out. I don't know if it will complete the rollout, but it will definitely further roll out, and we'll also provide training for specific training places to increase training across so physiotherapy, occupational therapy, nursing and social work, to make sure we have the right staff trained to do this kind of work.
Thank you, Tomas. Thanks, Chair.
Okay, thank you. And Alan Chambers.
Thanks very much, Chair, and thanks very much for the presentation and your answers. In the Assembly presentation of the programme for government, I heard very little mention of either costings or delivery timelines, but the document did seem to be full of hope. But in relation to health, I think it goes without saying that hope doesn't really provide a great level of pain relief, but action does. In terms of the waiting list initiatives that were referenced in the programme for government, have they been costed? And what amount of additional funding is required immediately to provide a year one kickstart to tackling waiting lists? And is there any guarantee that any immediate cash that we get in this financial year to tackle these waiting lists, is there any guarantee that funding will continue to be available in future years of the current mandate?
So the recognised demand capacity gap across red flag and time critical patients is about £76 million a year. So that's what we're spending now. We have an additional demand capacity gap for other planned services, about £80 million a year. And the backlog is costed at up to £135 million a year for up to 5 years. If we got non-recurrent funding, we could start dealing with the backlog patients. We reckon it's possible to spend up to £135 million per year. It's not simply not possible to spend more. There isn't enough healthcare to buy. That includes all available options, including the Republic of Ireland reimbursement scheme, using independent sector, using additional resources in-house. They provide a huge amount of additional treatments. So we're talking 20,000 patients in primary care elective, 4,000 patients through the reimbursement scheme. I mean, in total, something like 27,000 patients in extra treatment alone per year for up to 5 years. That we can spend very quickly. In some areas, the reimbursement scheme, independent sector, can be spent for very short notice. The long-term demand capacity gap will take time to build up. We need to invest in staff. If by magic we got £155 million current, which is the demand capacity gap we have now across time critical and the rest of elective, we couldn't spend it tomorrow because it takes time to train up staff. But the certainty of future spending would allow us to invest in the future and plan for doing this. Hopefully that answers this question, but 135 million is the per year's backlog. That can be spent very quickly.
Yeah, but the money that if you get an immediate sort of windfall, what you're saying that you can't spend it, it'll not actually produce results. Will produce results, but at a capacity, there'll be a cap on it. So are you only looking for additional money just to tackle this year's elective surgery and reducing the waiting list, or are you trying to get an amount of money that you'll be able to spread over the next 2 or 3 years?
I would want to do both. I mean, we can spend up to 135 million per year for the next 5 years to just deal with backlog. But if we did that, we'll clear everyone who's currently on the backlog. But because of the demand capacity gap, we have waiting lists again with new people coming in. So we need to do that and invest recurrently. At the same time, if we invest recurrently to deal with all the backlog, we would have overcapacity in a number of years. So it's a combination of non-recurrent investment to fix the backlog and recurrent investment to make sure we have sustainable workforce, transform the workforce, transform the services, so we have sustainable services. So it's a combination of both. What is clear that 76 million is enough for time critical and red flag, but not for the rest.
Can you carry money forward in the future years, or if you did get a big windfall in this current financial year?
In general, no. But we can spend quite significant money on waiting list in year.
So to continue the programme for government and the wish list of tackling waiting lists, next year you'll have to reapply for funding. You're back into the mix looking for, it's not guaranteed, in other words, in year 2 or year 3. You'll have to make bids for it.
The 76 million is non-recurrent, so that's this year. We don't have that guarantee for next year.
But any windfall that you'll get in the meantime, if there's any additional funding comes along to kickstart the waiting list initiatives, you'll have to bid for it again next year and the following year. It's not guaranteed. It'll not be sitting there waiting for you.
I mean, if non-recurrent funding is never guaranteed. If I get recurrent funding, we can do things recurrently. But at the moment we don't have that available.
Thank you.
Okay, Diana's a very, very quick question. I'm
Me
going to
too.
allow her in just very
Tiny
quickly. and
question.
then that's it.
Will the 76 million that you've been allocated, that you say is going to go to red flag and time critical waiting lists, will that ensure that you meet your cancer wait time targets?
And simply no. Hopefully the cancer waiting time targets will improve what we have, but the current wait, as you're very well aware, our performance against the 3 cancer targets is very poor. Especially the 62, the targets between referral and treatment, it's in the 30s or low, even high 20s. It's around 30,
Yeah.
and that's which is clearly unacceptable. I mean, I'm not trying to defend that. That is not an easy fix. That will take time to fix, because even if we got significant funding, the number of people who are sitting on that backlog essentially would have to clear up. That's not an easy task. A lot of those patients are waiting for diagnostics, pathology, imaging. So when they're being diagnosed, the 31 they target is close to 90%, which is not perfect but much better. So when we decide to treat someone, we can treat them fairly quickly. But it's getting them to the point of decision to treatment that takes long. So it's the first half. And that's imaging, diagnostics, pathology, seeing the doctor for the first time. That is taking way too long. The 76 million will allow us to maintain what we're doing currently, not to do more. I know that's not satisfactory, but that's the honest
I'll
answer.
write to you some follow-up questions.
Of course.
Okay.
Thank you.
Mass and Irish, thank you both very much. I think that was probably a longer session than we had planned for, but it's definitely been useful, and I think there's probably a lot more that we will want to ask, which we can bring with the Minister when he comes in on the 26th as well. So thank you. Okay, members, we still have quite a lot to get through, so I'm going to fly on here. Item number 6 is SL1, the Human Medicines Amendments relating to naloxone and Transfer of Functions Regulations 2024. If we could refer you to page 107 of the pack. The Department is proposing to make a statutory rule that will increase the number of services, professionals or organisations that can supply naloxone without a prescription or written instruction. And the rule will also remove remaining references in the Human Medicines Regulations to the now dissolved Public Health England and the Health and Social Care Board Northern Ireland. The statutory rule will be subject to draft affirmative procedure. We have officials coming in now just in case there are any questions, and it will be covered by Hansard. Wait till they come in. There he is. You're all very welcome. Thank you for attending today. We have Gary Maxwell, Head of Health Development Policy Branch, Canis Ward, Head of Medicines Regulatory Group, and Karen Simpson, Head of Medicines Legislation Unit. So thank you for coming along today. If I could just invite you if you have any opening remarks, and then we'll open up for questions from members.
Okay, thank you. Thank you for the opportunity to brief the Health Committee. My colleagues who have accompanied me today are the Head of Medicines Regulatory Group, Canis Ward, and the Head of Health Development Policy Branch, Gary Maxwell, and can assist in further clarification on the proposals. We are proposing to amend the Human Medicines Regulations 2012 to expand access to naloxone, a life-saving medication which reverses the effects of an overdose from opioid drugs. We are also proposing some technical amendments to the regulations with regards to transfer of functions following the dissolution of the Public Health England and the Regional Health and Social Care Board here in Northern Ireland. However, starting with naloxone, anyone can administer naloxone in an emergency, and it's considered a very safe medicine for both the recipient and the person administering, and it is already widely used both in the UK and worldwide. Current legislation allows only drug and alcohol treatment services to supply it to individuals for future use, usually called take-home naloxone, which limits the reach of this life-saving medicine. Therefore, 2 key changes are being proposed. First, to expand the list of services and professionals named in the regulations who are able to give out naloxone without a prescription. This means that professionals such as registered nurses and probation officers will be able to provide take-home supplies of naloxone where appropriate, should they wish to do so. Secondly, it is proposed to establish national registration services across the whole of the United Kingdom. This will enable all other services and professionals who are unable to be named in the legislation, including housing and homelessness services, to register and procure naloxone. It will not be a mandatory requirement for services and professionals listed in the legislation to supply naloxone. The powers in this draft legislation are enabling, simply allowing the supply of naloxone without a prescription. There are also safeguards within the proposals, including establishing mandatory training requirements for new services and professionals wishing to take on this role. This training would give participants an understanding of appropriate practices around storing and supplying naloxone and how to support an individual being supplied with naloxone. These proposals are being considered as a matter of public health and safety in the UK. Drug misuse deaths have doubled since 2012, and the impact of synthetic opioids on opioid-related deaths is yet to be fully understood. In 2022, opioids were involved in 60% of drug misuse deaths in Northern Ireland. Through its substance use strategy, Preventing Harm, Empowering Recovery, the Northern Ireland Executive has prioritised reducing alcohol and drug-related deaths. The committee will be assured to note that the infrastructure is already in place in Northern Ireland to deal with the expansion of those who can supply naloxone. Since 2012, the Public Health Agency has commissioned and operated a take-home naloxone programme. Naloxone was supplied 1,861 times in 2023 to 2024, and since the take-home naloxone scheme was put in place, it has successfully reversed an overdose in over 1,765 cases. PHA have mandatory training in opioid overdose awareness, basic life-saving skills and naloxone administration train the trainer, which all naloxone suppliers must complete initially and refresh every 2 years. In preparation for the expansion of the scheme, the Public Health Agency will be transferring this to an online option to target larger numbers. There are also technical amendments within this SL1 and statutory instrument in relation to the transfer of functions following the dissolution of Public Health England in 2020 and the Regional Health and Social Care Board in 2022. In Northern Ireland, as part of our programme of work to transform our health and social care system, the Regional Health and Social Care Board closed on the 31st of March 2022 and functions migrated to a newly formed Strategic Planning and Performance Group within the department. With regards to Public Health England, many of its functions have been transferred to the UK's Health Security Agency, which is also executive agency of DHSC. The proposed amendments will ensure legislation reflects recent changes within the healthcare systems in England and Northern Ireland. With regard to assembly procedures, the Human Meds regulations are made under powers contained within the Medicines and Medical Devices Act 2021, and within this Act the Department of Health in Northern Ireland is named as the appropriate authority in recognition that regulations of medicines is a devolved matter to Northern Ireland. UK-wide consultations on the proposals have taken place and have received significant support across the UK. In Northern Ireland, 100% strongly agreed the proposed list of named services and professionals that can supply naloxone without a prescription, with 91% strongly agreeing that training requirements for named services and professionals should include the storage and supply of naloxone. The importance of staff training on the administration of naloxone, along with advice and signposting on additional support, was consistently highlighted. These regulations will be subject to the draft affirmative procedure and will be laid before and approved by resolution of the Northern Ireland Assembly. Therefore, an Assembly debate on these regulations will be required. As the Human Medicines Amendments relating to naloxone and transfer of functions regulations 2024 is a joint SI with the Department of Health and Social Care in England, it will also be delayed for debate and approval in both Houses of Parliament. The SI was laid in Westminster at the end of July, with the debate in the House of Commons heard on Monday past the 9th of September. The House of Commons supported the amendments. The House of Lords debate is still to be scheduled. Following consideration of the SL1 by the Health Committee on the policy intent of these amendments, and if content, the Department will seek to lay the legislation next week commencing the 16th of September, and provisionally schedule the necessary Assembly debate for mid-October 2024, to allow the Committee the opportunity for further consideration of the legislation alongside any views of the Examiner of Statutory Rules. Thank you, and happy to take any questions.
Thank you, Karen. I suppose just as more a comment, over the summer I've been meeting with different pharmacies and other organisations and professionals, and naloxone was something that had come up, and I was shocked actually to hear just how often that has to be used. That was in the centre of Belfast, and we've heard a lot of that, I suppose, in the media as well. So I think anything that enables that certainly is very welcome. It's sad to think that it has to be, but essentially this is saving lives. So thank you for that. Danny, do you want to ask a question?
Thank you. I agree with the chair. It's very, very sad that, you know, obviously we have this level of overdoses in our society and drug addiction. And I know with Orlea we've met with families who have lost people sadly to overdoses, and it's incredible, that loss. The number really surprised me. 1,861 times used in 23-24. Reversed an overdose in 1,765 cases. That's 1,700 lives saved. You know, that is absolutely phenomenal, and it shows how useful and how life-saving this drug is. So the more people that have it, and the more people that have it in the community, and the more lives can be saved. So absolutely, I think this has to be supported, and I'm very glad to see it coming through. Just a wee question. I know there's two different types of naloxone. There's the injection and there's the nasal one. Just if there's a split on how they're given out, are people trained on the nasal one or trained on the injection, or does it matter? Is that
So it's primarily intramuscular, which is the injection at the moment, is the one that used, and that's been long used with those people, and drug treatment services and those who supply it are well used to that. I think as we roll it to other professionals and other providers, we will see the increasing use of nasal, because obviously people are more comfortable with a spray up the nose rather than injecting somebody. Both are safe. I think the intramuscular probably is more effective in that it more is taken into the body and it acts quicker. But I think if you have more people carrying the nasal, that kind of outweighs the risk of that. There's a slight cost difference between the two, so as we look to roll it out, we'll obviously look at the best value for money in terms of which is best to get which of those two provisions, but it's primarily intramuscular so far.
I'm very glad to see this move into a harm reduction model for people who use drugs is absolutely the right way to be going on this policy, and I would like to see it going further to include the provision of safe injection sites, and particularly in Belfast. I know we know at the minute that there are issues with people injecting drugs, and you know, in order to reduce harm to those people, provision of a site where they can do so in a safe environment with medically trained staff who can prevent overdose, reverse overdose, and save their lives, provide clean needles, dispose of needles, and provide medical advice to those people who need it, and I think would be a really good step forward and something we should be moving towards. So thank you very much for that, much appreciated. Thank you.
Thank you, Danny. Orlea?
Yes, just two quick questions. So yes, I am also really delighted to see that this is being brought forward, because the figures that you quoted there and that Danny had mentioned speak for themselves. That's all lives that have been saved through this medication, through this drug. So increasing the availability of it is basically increasing the potential to save more lives. So it's desperately sad how people obviously end up in this situation, but the important thing is that we can hopefully save a life when someone sadly reaches that point. My question is, so if when the Assembly debates the motion in mid-October, and if it goes through if it's went through the House of Commons, then the House of Lords, how soon then do you have a timeline as to when the organisations who have registered will be able to put this into effect? And also, is the registration process opened to other organisations who mightn't have already registered at this point? So will that continue to be open if there's further people that want to take up the scheme?
I suppose the legislation itself will come into operations like 28 days probably after, once the House of the House of Lords agree. Once we agree and then they agree, so we'd assume that it would be operational sort of coming around January time, and then the Public Health Agency will be involved in the implementation. So Gary said it'll be involved.
In terms of that Route 1, obviously those professionals will be able to supply it and those services named under that sort of Route 1 from that date, but obviously we'll manage that through the Public Health Agency, who run a national scheme here, a regional scheme, and that's really useful in terms of managing the rollout. In terms of Route 2, we're having ongoing discussions with our colleagues in DHSC in terms of making sure we're consistent and we're all following the same procedures in terms of setting that up and getting that registration process. I think the way that will work probably is the PHA will actually target specific groups that are, where those most at risk of overdose come to and are seen, and then push it that way. People can obviously apply for registration and the Public Health Agency will consider that as part of that process. But I think they're planning to take a kind of proactive approach of, we now need to look at more in homeless hostels, for example, or we now need to look at these particular sites, these particular providers, because that's where we're seeing some of those issues, and being proactive around that, and some of the other professionals as well. So they can start that as and when that process comes into place, once we agree what the registration actually looks like, and that's consistent across the UK. But I'd say it'll be a managed process, because obviously the demand for naloxone is going to increase, so that'll have an impact on supplies that are available, and we want to manage that in terms of rolling it out in a way that's effective and cost effective as well.
Yeah, there's training requirements, etc., embedded within the legislation, so it has to be managed as opposed to, I'm not going to say free for all, but
yes, of course.
It's a staged process. But there's certainly PHA or managing that process
and planning from now, because they've been involved in the discussions to date.
Very good, great work, thank you.
Thank you. That's been very useful. Thanks a million for that. I don't think I have no other questions at this stage. Just to ask members then, are they content with the merits of the policy and that the department makes a statutory rule? Content? Yeah. Thank you. Thank you very much. Members, item number 7 then is SL1, the Period Products Department of Health Specified Public Service Bodies Regulations Northern Ireland 2024. If I could refer you to the papers at tab 7, page 125 of your pack. The department is proposing to make a statutory rule that will specify the public service bodies that must ensure period products are obtainable free of charge as per section 2(3) of the Period Products Provision Act Northern Ireland 2022. And this statutory rule will be subject to draft affirmative procedure, and we have officials coming in now as well to discuss. Very welcome, thank you.
Thank you.
We have in attendance Chris Matthews, Deputy Secretary of Resources and Corporate Management Group, and Arian Culleton, Head of People, Organisational Development and Equality Branch. So thank you both for attending. Today's session will be covered by Hansard. If you wish to make your opening remarks, then I'll open up for questions.
Okay, thank you. So I'm conscious that the committee is a bit pushed for time, so I'll keep my remarks fairly brief. So this is a sort of a follow-up session from our initial submission on this SL1. We wrote to you back in August answering the questions that have come forward, so I'm not proposing to go through all of that now. There are a couple of points really to update you since we wrote. So in terms of specifically the timing around operational date, the current best estimate we have from consultation with the trusts is that we would hope to be able to go live in April of 2025 on this. To give you a bit of background in terms of the scale of what we're talking about here in terms of premises, we have in the initial canvassing of the trusts. Now this has to be refined through consultation and engagement with service users and patients and so on, but we're looking at 1,300 premises across 507 sites. So if you think about the sort of operational scale of what this means in terms of providing free products, a lot of challenges in there for the trusts who from various sessions before, under a lot of pressure, both financially in terms of their capacity in the trusts. So that's as much as I wanted to say, just to kind of update what we'd said in our letter of August, and happy to take any questions from the committee from that point on.
Okay, thank you, Chris. There is a couple of things that I suppose I specifically wanted to raise. I do feel that some of the information is still a wee bit patchy, and I would have some concerns just in relation to how we can move forward. I suppose the first one for me and the most glaring one is around the financial implications. Sure. Yeah. The response has stated that it's not possible to provide what those are, and whilst as an estimate, I don't think it's a huge amount of money. I think it's very difficult for the committee to sign off on a blank cheque or give approval on a blank cheque, because we don't know what the implication will be. We don't know whether that will have implications on other services or other things being provided through the department. And I think we need absolute clarity around even an estimate of what the cost would be, given that we're in a very challenging financial
Indeed,
situation.
yeah.
I don't want to be sitting here in 6 months' time and saying we're losing a service because trusts have had to find the money for this. And nothing should be pitted against each other. I suppose that's what I'm saying. So if there's, is it possible to get some clarity around that?
So there's probably two parts of this. Just I think to be sort of clear with this committee, one is that because of the department is in a deficit position, whatever the cost is, essentially we're just going to be deepening the deficit to pay it. The second is that we would hope somewhere around sort of October, November, post the sort of engagement exercise that the Trust are now going to do, where they will have refined across those 1,300 premises, which they're going to have to kit out, how they're going to do it. So it's, whether you have dispensers, whether you have... There are all these kind of discussions that are going to have to be had that will drive what the final cost is. What we didn't want to do was give you a kind of a sort of finger in the air estimate that would be of no use to you in terms of your decision making. Towards October, November, we would hope to be able to give you at least some kind of estimate, because that's the point at which we'd be looking to go to procurement.
Okay. I suppose I'm conscious that I know the Department of Education and Justice have both completed this. It's my understanding they would have had costings. So I'm just trying to understand how that's different, how they were able to get costings and we aren't.
It's a question of scale, and also how the each individual trust premises approaches it. If you the variety of the different places in which you might be providing these services, it's so different. It's really difficult to look at education or justice and compare what the demand might be, what the relative usage is going to be. And I think the costings for us are likely to be very different from theirs.
So am I right in thinking, Chris, then you think that post-October, November you would be able to provide some level of
That's in our current plans. That's when we would be looking to go and procure to get contracts. So by that stage we would need some costings, and at that point we should be able to tell you.
And if the committee were to defer this again until that was available, will that impact on the procurement process?
No. I mean, it's a statutory obligation that the Act is in place.
Yeah.
We know we have to comply with it, so it won't affect that progress if you're not comfortable making that call now.
I think it's just a very difficult position for us to be in at this stage. And again, we're all supportive. It's come through the Assembly. I mean, in terms of the legislation, it's a very important piece of legislation. But in terms of due diligence, I think it's important that this committee understands the cost of that and the implications, in relation to that. I suppose the only other question, because other members may want to ask more around the financial end of things, you did advise that the department had consulted with the bodies specified. What were the views? What were the feedback? Do we know?
So in terms of discussions with the trusts, obviously they have concerns about the cost, and they're asking us, how we're going to meet those costs. And they also then have the sort of operational challenge of finding the people to stand this service up, working out how they're going to provide the service, and then the sort of procurement. Again, the kind of challenges that you would expect to see in this kind of operational implementation. There's nothing unusual about the thing in of itself. It's just the context in which it's happening means it's much more challenging for the trusts to have confidence about the financial implications of this, plus also then the operational impact of the people that need to lead on this.
And suppose then coming out of that, and again with the if trusts are being expected to find this in their own budgets, is there a potential that some trusts may not implement it if they're saying they can't afford to?
So they're statutorily obligated to do that, so that's not a conversation we can have. Okay. I think probably if it's helpful to the committee when we talk about the costings, it might be helpful if we were to. We won't be able to show exactly where the money came from, but we might be able to show the equivalent services that the cost of implementing this amounts to. If that's something just to give you a sense of the impact, or give you a sense of to calibrate your decision at that point.
Okay. I'll open up to other members, and then we can have a discussion at the end of where we want to go. Thank you, Chris. Danny.
Yeah, thank you, Chair. I'd noted from the report several other areas in the UK already do this. Scotland, for example, already does it. I assume there would be some sort of comparable sized hospitals, trusts that you could have looked at. Has that been done? Have you?
So in looking at other jurisdictions, they don't provide services universal as the one that's provided here. So again, the services tend to be, in other jurisdictions sort of neighbouring us, they tend to be either for inpatients or patients. What is proposed under our Act is for universal access for basically anyone who's in those buildings can get access to those services.
Is it not correct that Scotland do?
So Scotland, I think with Scotland it's mandated for patients, but it's other people can access those services. For in our system, the statutory mandatory access is for everybody.
Scotland not for members of the public?
Sorry,
Is it not fully right across?
I think they can access it, but I don't think it's mandatory in the same way as this here. We can check that, but from what I understand, that's the position in Scotland.
From my reading of the report, maybe I've got it wrong, was that the Scottish hospitals did provide.
Yes, they do. Yeah, but I think it's to patients, but I think it's also open to members of the public. But it's not statutorily mandated that it's open to them. That's my understanding.
If that was the case that they do provide, would there be a comparable case to make for how much it would cost here?
It could be instructive for trust in working out what the procurement costs are likely to be.
That hasn't been done yet.
We haven't done that yet. No, I mean the trust, as I say, the work we've done so far with the trust is just to scale up to look to essentially scope the size of what we're talking about and how long it might take them to get to the point where they're ready to procure. So they haven't essentially trusts are not in a position to give us an indication of what they think it's going to cost them.
Okay. And you think you'll have those estimates by October, November?
That's yes, because if we're going to meet our deadline to procure, then we need to know what it's going to cost us at that point.
My other reading of it was that trusts don't have to provide this if they can't afford to do it. Is that correct?
No, I think it's statutorily mandated, so I think they have to provide it.
Right. Right, just the wording, and see if I can pull it up. Bear with me. If anybody wants to go ahead,
Yeah, I'm going to take Diana. I'm just very, I suppose, just as we were chatting there, and obviously procurement and all that's happening then after we've had this discussion, and we've already had it in front of the committee. Is that would that be normal procedure that we would be doing things? Would the committee be asked to sign off on SL1 before those things, like the costings and everything are done?
I suppose because it's a private member's bill, it's a bit different in that ordinarily, if it was a policy coming from the department, we would have costed it before we got to the legislation phase. Because this legislation has come from the Assembly, we're sort of costing it after the fact. So it sort of depends.
And I suppose just in terms of your colleagues then in Education and Justice, were they in the same position that they were presenting it to the committee before it was costed?
I'm not sure about that. I haven't seen any of those other sessions.
Okay.
They may have been able to get to costings earlier than we were, but as I said before, the trusts have found this quite challenging to get their arms around.
Okay, sorry, Diane.
That's okay. I absolutely agree with your assessment. It's very, very difficult to give assent to something that you don't actually know all of the implications and the costings around it. So I do agree with that. I suppose, number one, I stupidly missed the number of sites and the extent of it. Maybe if you just
sure. It's 1,300 premises across 507 sites. That's all. That's for all 5 of the trusts.
It's a very significant investment. And when you're doing the procurement, I suspect that this may be one of those things that starts off at a different level just to where it ends up. Will there be a scale that you're looking for in terms of that, or how will you do that?
I think that's part of what the engagement will tell us is likely demand. So I think one of the things that's unknown at the minute is depending on the location you make something available for free, that will probably drive a certain amount of demand, depending on who is using that facility and so on.
Have you looked at other areas? For example, I mean, I know that for quite some time, further education establishments have actually been making period products available. Have you looked at the trend and the demand trend in those establishments?
I don't think so. I mean, it's something we could look at. with the trusts. The trusts have asked us to look at that. I don't think we've been able to get any information on that so far. I think it could be helpful, but I think there's the engagement with service users for the trust to do as well, so that they get to the point of understanding.
No, I accept that, but
Yeah.
just as a kind of a bit of a...
We haven't done it yet, but it's not to say that it couldn't be useful.
Okay, thank you.
Okay, thank you. I have no other members. If Danny, do you want to come back in?
Yeah, I'm just going to read just from page, I think we're on 126, the Scotland. In 2021, the Periods Free Precision Scotland Act 2021 received royal assent. The Act places a duty on local authorities and education providers to make period products obtainable free of charge, make period products available to anyone who needs them.
Okay.
So the 2021 Act establishes a power of Scottish ministers to specify via regulations public service bodies who must make period products obtainable free of charge in their premises.
Okay, so we may have understood what's been specified there. We'll have to go back and look at the regs and see what's been specified there.
Okay, no problem. The second bit was just about the trusts. The regulations will come into operation when the Health and Social Care Trust confirm they are in a position to fulfil their requirements as specified bodies under their Act. So the trusts have to confirm
yes, that
they're
was-
in a position to be able to do it.
I think that's from our
before-
letter to you in August, isn't it? Yeah. So I think that was our way of saying that we, until the trusts are able to do their full assessment of what it's going to take them to implement this, we won't be able to tell you when. But what that doesn't mean is that there's a kind of an opt-out for the trusts.
The trusts have to produce a written statement as part of the legislation to outline how they plan to implement their various schemes, and I think maybe that perhaps is what that means from memory.
The wording is quite confusing.
So apologies for that if we've caused any confusion there, but there's no, once something is statutory, there's no opt-out on those terms. But I appreciate that the wording could have led you to that conclusion.
No problem. Okay.
Well, thank you. And I suppose just to make it clear, I mean, this legislation was brought in because to try and for people who are probably the most vulnerable in our society, and try and reduce the burden of that on them. And obviously, as I said earlier, we all are very supportive of that. I suppose my concern is if we're signing off on something that we don't have costings for, and further down the line we're told, well, actually, because the committee has agreed to this, we have now lost a critical service in health or something like that, and it ends up that these things are being pitted against each other. It's only one example of one of the concerns that's in my mind, but I just think we do need absolute clarity on some of this. I think it would be remiss of the committee to approve something that we don't have any real idea. We actually have no idea how much this is going to cost, and what the implications would be of that. And that's not to say that if it comes in at £10 million, we're going to say we're not approving it. I just think we do need to understand that. So that's maybe something we can have a discussion about now.
And I apologise for not being able to give you those numbers now.
No, and I mean, I don't know why things are done in the order they're done, but it would have probably been, for me, that would have been one of the most important things for the piece of information that we could have had. So members, I suppose that brings us then to the question, are we content with the merits of the policy and that the department makes a statutory rule, or given the issues that have been raised, do we wish to defer? Yeah, I think maybe we should, because we do need the clarity around the implementation and the cost, and I think that until we have that, we probably can't really make a decision on that. So if we can get that whenever available, then we can revisit it. Is that okay? Okay. Thank you both for coming in this afternoon. I really appreciate that. Thank you. Thank you, members. So defer until that's available. Yeah. Okay, members. Item number 8 then is the SL1, the Recovery of Health Service Charges Amounts Amendment Regulations, Northern Ireland 2024. If I could refer you to page 139 of your pack. The Department's proposing to make a statutory rule that will apply an inflationary uplift to current tariff levels from the 1st of October for the collection from persons or organisations making compensation payments to road traffic accident casualties of the costs incurred by hospitals in treating the casualties. The recovery scheme includes all cases where an injured person receives personal injury compensation and costs of ambulance services. The charges are mainly paid by the insurance industry and are collected on behalf of HSE trusts by the Compensation Recovery Unit, a branch of the Department for Communities. The statutory rule will be subject to negative resolution procedure. I just have one quick question on it. Where it says that charges are mainly paid by the insurance industry, in cases where they're not, do we know how is the individual liable? And if so, in that case, is there any mitigations or any?
I'm happy
Can we ask that?
to follow up on that. I think it's where maybe there's cases there's no insurance.
Okay.
So there is, and then there maybe have to go through a legal route. But
Okay.
That's just the best.
Yeah, it's just to get
Yes,
an
but we can
understanding of that.
certainly
Yeah.
check
No,
that out,
that's a problem.
Chair.
Thank you. Are members content then with the merits of the policy and the department makes the statutory rule? Yeah. Thank you. Item number 9 then, Department of Health. It's a written briefing on the implementation of the Hospital Parking Charges Act at page 143, and it includes a clerk's memo and a written briefing from the department providing an update to the committee on the progress of the new traffic management system for hospitals. Are members content to note?
Can I just raise one issue? I have been contacted by a couple of my colleagues. If I just can find the email, sorry, apologies, came up on me quicker than I thought. We're parking at the Ulster has increased exponentially over the last number of, apologies, come on. Where are we? Sorry, won't do this for me now. And I just wondered, had anybody else got any information on the increase in parking charges? So this is a response to Michelle McElveen of the 5th of September, where car parking charges at the South Eastern Health and Social Care Trust have increased significantly. It doesn't give you the exact date, but it does give you some guff around why they had increased. I just wondered, had anybody anywhere in the other trusts got any information around that? Because I'd like us to ask why that is the case.
And is it just in the Ulster?
Yes, this is the Southern Health, Southeastern,
Yeah.
Health and Social Care Trust. I'm not used to saying the Southern, complaining. I said automatically. And I just wondered, had anybody done that? They say they've not increased public car parking prices since 2015. But I wouldn't like, having abandoned the free car parking, that we were now going to be faced with a position where trusts would feel the need to increase charges.
Albeit it's I'm assuming it's temporary, so why bother?
Yes, so and just
I thought you
asking.
meant spaces, but you mean charges. You mean charges, yeah.
We could write to the trusts, all of the trusts, to say
Yes, to see
on
what
it.
they've done and whether or not this has been a licence to do something to increase charges.
No, absolutely. No, thank you for raising it. Yeah. Are members content to note then the briefing and the update that we've received? Thank you.
Can I just confirm, Chair, we're getting a briefing every 8 weeks
8 weeks,
on that?
yeah, the next one's
so
November.
November, okay.
And I'm hoping that, given that it says that, I think it's Antrim and I forget the second hospital, but that they're hoping that they will be
I thought it was the Royal and
ready
It
to
would be
go
wonderful if it was.
in October and November.
Royal Victoria and
Royal-
Ulster Hospital
Yeah.
are due to be
Ulster.
completed by November 2024.
So hopefully at that stage we will see that progress, but we'll keep an eye on it. Okay, thank you. Okay, members, item number 10 then is correspondence, as I said.
Sorry, apologies. So when we're doing the letter to the trust, could we ask for an update from all of the trusts on the implementation of the free car parking?
Mhm.
From all of them, other than getting an update on one or two, because that'll let us know whether those who are furthest away from the implementation have,
That is what they do.
I
have
think
raised the
that, well, I
prices.
think it has listed of where everyone's at. But what you're asking about the prices?
Yes.
Yeah, well, that is what we're going to ask.
Yeah.
Who has increased or have they
Yes.
increased? Sorry, yeah, I thought you meant in terms of the implementation of the free parking. So
Yes.
that's what we're talking about.
Just
in
if
terms
they could actually include that in their letter, that would be really helpful to have the two things together.
Is that not bypassing the 8-week reports that the department's given us if we sort of go over their head, as it were? I mean, is that...
Yeah, because this is what that report is, Diane, so that's what we'd agreed with them.
We'll still be able to compare the two with Diane's letter about the costs. We'll be able to compare that with the
implementation phase.
Implementation phase.
Yeah, yeah.
Because I do think that's important.
Yeah, well, that's what I'm saying. If we can get the
Yeah.
information on any increase to parking charges that has and where it's happening, if it's happening across the board, if it's not, but also because it says from that it lists all the different sites and what surveys have been completed and all of that. So
Sorry, Antrim Area Hospital is October.
yeah,
So it is, and then the Royal and Ulster in November.
yeah. So that's where they're at in terms of those hospitals, but the rest of them then I would say in November we'll have the next update. Okay, thank you. So item number 10 then is correspondence. And as mentioned earlier, there's quite a lengthy list of correspondence and a list of the annual reports and accounts received. So that's on page 178, page 180 and page 181. And there's a list of suggested actions for each item of correspondence at tab 10.1. Are members content with the suggested actions for each of those?
Sorry, apologies. Chair, just to highlight, I'm looking, there was a lot. I'm just trying to get the one that it was, just a number of them. In particular, obviously the urology review will be also included in our ongoing and forward work into the reviews, etc. It's just something I think perhaps hasn't been spoken about in public session, I think, since we've had a committee too often, the urology
We
review.
just had
but
a statement, I think, from the minister. didn't we,
Yeah,
the
but
Assembly?
it's important to highlight that will be part of our ongoing work of the review. And also, let me just find the next one here. There's a lot. Under the recommendations of the strategic priorities, I think it's worth going back to the action log updates that we kind of had expressed before. We'd spoken about from the department that there are actions that they've taken. There's actions that's recommended and reviews that take place, but this is the department's priorities themselves. These are their actions they want to take. So how best can we hold them to an account on that is to ensure that actually that work is ongoing. So in terms for the committee, I think it's important that we kind of get that log from them as to, okay, this is what's been done, this is what hasn't been done. Otherwise, this is just another attempt to bury us in a volume of information to say, this is all the great work that we're doing. We'll never get back to you as to what we've done with it, but here you go. So I think it's important to kind of get into that mindset, because I think we're noticing some changes already in terms of the updates on these are the things that you're previously asking for. This is what we're updating. We are certainly getting that feedback, so it's important that we continue to get that back as well.
I think that's what we're going to ask for, quarterly updates on those.
Okay.
So that's one of the suggested actions, because I think that is very important. So are we happy with quarterly updates then on those? I suppose because they are bigger. Yeah. Okay. Thank you. So are members content then with everything, all the other suggested actions in relation to?
See the issue of the autism reviewer.
Yes.
It is a good step forward, and it is to be welcomed, and I'm very happy that we've got to where we've got to. And I may have missed this in your forward work plan, Keith, so don't shout. Is the autism reviewer going to come to committee? And if so, are we happy to invite some of the organisations around the broad autism world to come and maybe present as well?
Yes, sure. The autism reviewer, it wasn't on our initial list of priorities, but certainly if members wish to schedule, we'd be happy to.
We do have
work
two
programme.
pieces of legislation in relation to autism. We are quite unique in that context. The Autism Review is there to assess how that is being implemented, and I think it doesn't have to be a long session, but I think it might be a useful one to consider.
Absolutely. Yeah, okay, happy enough with that. Okay, members, so item number 11 is the review of children's social care services, and the meeting will now go into closed session.